Okay, so the clinical manifestations of nephrotic syndrome. The most common presentation of nephrotic syndrome, which is a cardinal sign of nephrotic syndrome, is pitting edema. Pitting edema, okay? This edema is sudden in onset, it is a dependent edema in dependent area mostly, okay? And the mechanism of this edema are two mechanisms: the underfill mechanism and the overfill mechanism. Okay, underfill mostly goes with the children, and the overfill explains mostly the adult edema. Okay, what really happens is that we have a low albumin due to proteinuria and hypoalbuminemia. So we have low albumin in the blood vessels. This low albumin will decrease the oncotic pressure, okay, and this will lead to fluid extravasation from the intravascular space into the extravascular space. That's why we have the edema. The overfill theory says that we have renin, angiotensin, aldosterone overproduction or overactivation. Okay, that will lead to fluid retention and eventually to the edema. Okay, the sites of edema are multiple, maybe anasarca, generalized edema, we may have ascites, okay, but the very important one is periorbital edema around the eyes, and this is due to the thin skin periorbitally. So here is periorbital edema. So don't forget, it is the cardinal sign. There is no nephrotic syndrome without an edema. What other clinical manifestations or symptoms we can see in nephrotic syndrome? The patient will come to you with anorexia in a lot of cases, okay, abdominal pain, malaise, okay. Actually, the urine will be frothy, and this is due to the the protein in urine, okay, proteinuria. We will have frothy urine. Normally, sometimes we have frothy urine, but in nephrotic syndrome it will be extra normal frothy urine, okay. Anorexia, abdominal pain, malaise, hypotension, okay. I told you that 25% of cases they in atypical nephrotic syndrome may have hypertension, but also we may have hypotension if we have sudden decline in serum albumin. We may have hypotension. And don't ever forget the atypical presentation of the nephrotic syndrome, the hypertension and the hematuria, okay. Actually, if we have atypical presentation, that indicates that we have other types than minimal change nephrotic syndrome. This is about the clinical manifestations. Now let's move to the diagnosis of nephrotic syndrome. How to diagnose nephrotic syndrome? From the definition, we told you that it is a proteinuria, so we have to check protein in urine. As a beginning examination, we may see the Debestic test. If we have +1 or more on Debestic test, okay, on 2 to 3 random readings, it suggests persistent proteinuria. Just have a suggestion of proteinuria. This is the Debestic test. If we have more than +1 in 2 or to 3 readings, okay, then after that, to confirm, we do a protein to creatinine ratio in urine. If it is more than 2, then this is a nephrotic range, okay. This is a nephrotic range. This is about proteinuria, okay. I told you also we have hypoalbuminemia with below 3 gram per deciliter albumin, serum albumin, okay. I told you also we have hypercholesterolemia, okay, above 250 milligram per deciliter. We have hypocomplementemia. In some cases, okay, if we have decrease in complement system, so it is mostly things other than minimal change nephrotic syndrome. It may be focal segmental, maybe membranous, membranoproliferative, okay. And if we have a signs of atypical nephrotic syndrome, like if we have a hypertension persistent more than 1 week, if we have hematuria, if we have extreme of ages, if we have complement decrease, okay, other infections like hepatitis B and C and so on, we have to do renal biopsy. So the indication of renal biopsy in nephrotic syndrome, if we have a suspicion of other than minimal change nephrotic syndrome, either by symptoms, okay, like the symptoms I told you about atypical nephrotic syndrome, or by non-responsiveness to steroid treatment, because usually the minimal change nephrotic syndrome will respond to steroid. If it doesn't respond, then you have to have a suspicion of other types, okay, atypical presentation. The biopsy is done before the steroid treatment if we have symptoms that indicates things rather than the minimal change, okay. Also we can check electrolytes, creatinine, blood urea nitrogen, renal ultrasound may be beneficial in some cases, okay. Again, biopsy just when minimal changes is not suspected, atypical presentation. Don't forget, just get back to the definition, and from each part of definition you can know what investigations to do, okay, and add to them the ultrasound, the blood urea nitrogen, the creatinine, the electrolytes, and the biopsy. Okay, now let's move to the treatment of nephrotic syndrome. Actually, to treat nephrotic syndrome, you have first to treat the disease itself and to treat the symptoms and complications of nephrotic syndrome. To treat the disease, okay, if we have typical features of nephrotic syndrome, typical feature, then it is in 80% of cases minimal change nephrotic syndrome, okay. Mostly it is minimal change nephrotic syndrome, and mostly if we have minimal change nephrotic syndrome, the treatment is by steroid, even without taking biopsy. There's no need to take biopsy if we have a typical presentation of nephrotic syndrome. What is the steroid treatment? We give prednisolone, okay, prednisone for with about 2 milligram per kg per day, okay, but do not exceed 60 milligram per day, okay. So 2 milligram per kg per day, okay, do not exceed 60 milligram. So if we have for example 10 kilogram children, we multiply this by 2, we have 20 milligram per kg per day, okay, prednisone. 90% of the patient with minimal changes nephrotic syndrome will respond within 4 weeks. 10% may respond after 4 weeks, okay. If they respond to the steroid treatment, then we give prednisone for 12 weeks. So duration of treatment of nephrotic syndrome is for 12 weeks. If we have frequent episodes, okay, or resistant to treatment, then we have a suspicion of other types of nephrotic syndrome. Then we have to give additional immunotherapy. If there is no response, okay, renal biopsy is indicated, because minimal change nephrotic syndrome in this case is not suspected, okay. You can give a prednisone the 2 milligram per kg per day once daily, okay, or you can split it among the day, whatever you want. This is for the typical presentation of nephrotic syndrome, What if we have focal segmental glomerulosclerosis, the other type of nephrotic syndrome? By biopsy we found it is focal segmental glomerulosclerosis. Okay, actually focal segmental glomerulosclerosis has no clear effective therapy. Okay, 30% only will respond to steroids. Others should use other immunosuppressive therapy. So remember, most of patients with minimal change will respond to steroid. Focal segmental only 30% will respond, so you give other immunosuppressants. Okay, what if we have minimal membranoproliferative glomerulonephritis or membranous nephrotic syndrome? They usually do not respond to normal steroid or standard steroid. We have to give extensive or aggressive chronic steroid and plus immunosuppressive therapy, okay, so that we treat the membranoproliferative or the membranous. Now the important thing here in congenital nephrotic syndrome, we have to do special measures. Okay, early nephrectomy and dialysis with aggressive medical therapy is the thing to be done. Okay, this is the treatment of congenital nephrotic syndrome. It is the worst among them all. So you have to do early nephrectomy, renal dialysis, aggressive medical therapy. Okay, so in typical cases steroid. In atypical cases like focal segmental glomerulosclerosis or membranous proliferative, steroid plus immunotherapy. Okay, immunosuppressant, other immunosuppressant. In congenital, nephrectomy plus dialysis plus medical therapy. This is treatment of the disease itself. What about the treatment of the symptoms and the complications of nephrotic syndrome? First, the most important symptom, the edema. If we have a mild edema, we can just restrict salt intake. Salt restriction may be good. Okay, if we have a severe edema, we can give loop diuretics, but loop diuretics will also make us lose more albumin, okay, with the fluid, because increase glomerular filtration rate. So what to do? We have a hypoalbuminemia state and you are giving loop diuretics, so you are exacerbating or aggravating the hypoalbuminemia. So you have to give caution, 25% albumin, okay, parenteral administration. So you give diuretics, and with diuretics you give albumin, okay, to prevent hypoalbuminemia. So this is treatment of edema. Depends if it is mild or severe. Mild, salt restriction; severe, the diuretics. If we have a pleural effusion, of course, in most cases we have to drain the pleural effusion if it is significant. If we have acute hypertension, it is rare to be presented with acute hypertension. It's a atypical presentation, 25% of cases. If it is acute, you can treat with beta blockers or calcium channel blockers. This is about the symptoms of nephrotic syndrome. What about the complications of nephrotic syndrome? What are them, and what is treatment of the complications of nephrotic syndrome? Okay, this is what I'm going to talk about in the next video. It will be short video, the next one. Okay, thank you very much for watching this. See you in the next video.